At ESMO 2020, I had the honor of presenting the final results for Keynote 361, which was an open-label, randomized, three-armed trial in first-line, untreated previously metastatic urothelial carcinoma. The three arms were cytotoxic chemotherapy, both cisplatin and carboplatin-based by treatment investigator choice. And the two interventional arms were pembrolizumab alone, and there was a combination arm of cytotoxic chemotherapy plus pembrolizumab. Now, the background for this trial was that we have known through multiple already published and standard of care studies that immune checkpoint inhibitors like pembrolizumab, which is an anti-PD-1 antibody, have value and efficacy in urothelial cancer. So, for example, Keynote 045 proved that it was better than cytotoxic chemotherapy in the second-line setting and is now standard of care. Similarly, we have been using pembrolizumab and other immune checkpoint inhibitors in the cisplatin-ineligible patients whose tumors express PD-L1. So, we have known that immune checkpoint inhibitors do have value in urothelial cancer, and this Keynote 361 trial was an attempt to check if the combination of chemotherapy plus pembrolizumab would have value in the first-line setting in different context. And the reason for that, in urothelial cancer particularly, where patients have multiple comorbidities and there is frailty in patients, often elderly, there is significant drop-off in number of patients going on to subsequent lines of therapy. Between first line and second line, for example, is 50% of the patients may not receive second-line therapy, either because the disease overwhelms them or the comorbidities overwhelm them. So getting effective therapies upfront, frontline, is of value if achievable and if efficacious. So Keynote 361 was one of many trials designed with that end in point. So the study was designed as a three-arm trial, as I mentioned, with dual primary endpoints of overall survival and PFS, which is progression-free survival, as assessed by blinded central review, comparing the cytotoxic chemotherapy plus pembrolizumab arm versus the standard of care chemotherapy only arm. Unfortunately, the study, which enrolled 1,010 patients, did not meet either of the dual primary endpoints, and therefore it will not change practice. So my bottom line take-home message from this study and similar studies in the same context is that the magnitude of benefit of adding immune checkpoint inhibitors to cytotoxic chemotherapy is not large enough. Perhaps we were over-ambitious in assessing the treatment effect in these trials. And there is clearly a role for immune checkpoint inhibitors that will be there even after this and other negative trials in this context. But perhaps we need to be more strategic. And one approach that has proven already to be successful is to use cytotoxic chemotherapy upfront, where its lack of selectivity may be its biggest advantage, and try to reduce the tumor and then put them on immunotherapy for the long-term durable remissions and durable responses that we know occur with these agents. So perhaps the solution is not to add them together concurrently, but rather stagger them, chemotherapy first and then immune checkpoint inhibitors. And this approach was successful as presented in ASCO 2020 with the Javelin study and has become the standard of care now. And therefore, I think adding them concurrently, at least at this point, because of the lack of good markers like CPS, combined positive score, was used in Keynote 361. Unfortunately, it did not discriminate between patients who would benefit from the combination versus those who do not. And therefore, our lack of good quality biomarkers in this combination approach is a significant drawback. So for now, the standard of care has evolved into chemotherapy followed by switch maintenance with avelumab, for example, and another immune checkpoint inhibitor, an anti-PD-L1. Until we get better biomarkers and plan for studies with smaller treatment effects, we will not be able to, for the current time, combine them together at the same time. Pembrolizumab and immune checkpoint inhibitors do overall, in general, have a better safety profile than cytotoxic chemotherapy. We are all agreed on that. And the pembrolizumab monotherapy arm was an attempt to perhaps identify patients who could avoid the cytotoxic chemotherapy toxicities if we could identify them well and benefit them. Unfortunately, at the current time, chemotherapy is still the first line therapy of choice. There is one narrow sliver of patients who are not platinum eligible at all, either cisplatin or carboplatin, and for them there is FDA guidance on using one of the immune checkpoint inhibitors, pembrolizumab, for example, as the treatment first line. But other than those patients, in general, chemotherapy, whether it is cisplatin based or carboplatin based, followed by switch maintenance, is currently with immune checkpoint inhibitor is the standard of care. But obviously, immune checkpoint inhibitors are associated with fewer toxicities and therefore will have a role going forward.